Hello everyone, myself Dr. Saradha, Assistant Professor, Department of Periodontology, Vinayaga Mission, Shankaracharya Dental College. Today I am going to discuss on the topic Furcation involvement and its management. So let's see the topic. First we are going to see the introduction. First, before knowing the furcation, we should know the meaning of the furcation. Furcation, it is an area of complex anatomic morphology that may be difficult or impossible to debride by routine periodontal instrumentation. Furcation involvement is one of the clinical finding that may lead to advanced periodontitis and it can lead to poor prognosis. Then we should know the terminologies of the furcation. So first we are going to see the root trunk. The root trunk, it is the undivided portion of the root or the distance between the C is a undivided portion of the root. Then root cone. The root cone is the divided portion of the roots is called root cone. In single toothed teeth it is called as root cone, whereas in case of multi-rooted teeth it is called as root complex. So entrance it is the transitional area between undivided and divided part of the root. That is the roof of the furcation is the fornix, and the degree of separation. Degree of separation is the angle between the two roots is called the degree of separation, whereas divergence is the distance between the two roots is called diversion. Next we are going to see the etiological factors. So what are the etiological factors? Plaque associated origin, contributing anatomical factors, endodontic origin, occlusal origin, iatrogenic origin and combined origin. So first we are going to see the plaque associated origin. In case of plaque accumulation in the furcation area, it will lead to the inflammatory process and it leads to the attachment loss and bone loss. Whereas other contributing factors includes furcation entrance diameter, root trunk length, presence of root concavities, cervical enamel projections, enamel pearls and bifurcation ridges. First we are going to see the furcation entrance diameter. In 60% of the molar furcation entrance, it is less than 0.75 millimeters. In case of short root trunk, it leads to the early involvement of the furcation but it is more accessible. It leads to the better prognosis. Whereas in case of longer root trunk, there will be late invention of the furcation involvement, but it is less accessible and leads to unfavorable prognosis. Next we are going to see the root concavities which are present on the proximal root surfaces, which makes the instrumentation almost impossible in that area, and there will lead to the increased plaque retention and leads to the periodontitis. Whereas in case of cervical enamel projections, these are the developmental anomalies which extends from cemento-enamel junction towards the furcation area. So it will be more in case of maxillary and mandibular second molars, which leads to the plaque retention and leads to the periodontitis and furcation involvement. Next we are going to see the another developmental anomaly is enamel pearl, which is a nodular like enamel which is seen at the entrance or fornix area. So it is relevance is less than cervical enamel projections and it is predominantly seen in maxillary second molar, which also leads to the plaque retention and leads to the periodontitis. And bifurcation ridges, these are running across the roof of the furcation connecting mesial and distal roots. It is formed mostly on the cementum. And next, occlusal forces. In case of excessive occlusal forces, because of the excessive occlusal forces, inflammation and tissue destruction will be happening in the furcation area. In case of iatrogenic factors, faulty restorations and perforations during root canal treatments and overhanging margins or poorly contoured restorations leads to attachment loss in the furcation area. And pulpal pathology, in case of accessory canals or in case of in the absence of established periodontal involvement or incomplete resolution of the endodontic involved lesion leads to the involvement of the furcation area. And other factors which includes root fractures. The root fractures which involves the furcation, also there will be rapid localized alveolar bone loss will be seen. If root fractures involves the trunk of the multi-rooted teeth and will extend into the sometimes it will extend into the furcation area and it forms a isolated furcation defect. In these cases prognosis will be poor and results in the loss of the tooth. Next we are going to see the classification which is given by the Glickman in 1953. There are 4 types. Grade 1, it is an incipient or early stage in which there is will be pocket will be supra-bony pocket. There will be mild amount of bone loss will be there, but it will not be seen in the radiographs. Whereas in case of grade 2, it is called cul-de-sac lesion. There are 2 types. One is buccal furcation and another one is lingual furcation. In case of molars, there will be buccal and lingual furcation. In case of grade 2, there will be bone loss in the one side. Either it can be in the buccal or lingual, and another side there will be alveolar bone will be intact. Here in this picture we will see there is buccal furcation is involved, but in case of lingual there will be an intact furcation, intact alveolar bone is there. In case of grade 3 involvement, this is through and through lesion, that is both buccal and lingual furcation are involved. The probe will be passed completely in the furcation area, but it is covered by the soft tissue. Only radiographically we can be able to see. In case of advanced grade 3 only we will be able to see clinically. In case of grade 4, both through and through lesion, that is both buccal and lingual furcation are involved, and there will be attachment loss also seen, which is clinically visible. Next, coming to the Ham's classification, this Ham et al. In 1975 given a classification based on the horizontal defect, that is horizontal loss of the periodontal support which is not exceeding 1/3 of the width of the root. In case of degree 2, that is horizontal loss of periodontal support exceeding 1/3 of the width of the tooth but not encompassing total width of the furcation area. In case of degree 3, that is complete, that is true and true, as in case of Glickman's classification like grade 4. We will see there is complete both buccal and lingual furcation in intact bone will not be there. Next, coming to the diagnosis. Mostly the diagnosis, extent of furcation involvement which is difficult to diagnosis. So we have to consider both clinical and radiographic. Clinically we have to do using a neighbor's probe. So this is a neighbor's probe. There will be check both buccal and lingual furcations in case of lingual or palatal furcation. So buccal furc of maxillary molars and buccal and lingual furc of mandibular molars are normally accessible for examination by clinical probing, whereas distal furcation which is located midway buccolingually probing from both sides, whereas mesial furcation which is located 2/3 towards the palate and it should be probed from palatal aspect. Next, the diagnosis, slight radiographic change. Even the slight radiographic change in the furcation area should be investigated, especially if there is a bone loss on the adjacent roots. Diminished radiodensity in the furcation areas in which outlines of the bony trabeculus suggest furcation involvement. Whenever there is marked bone loss in relation to the single molar root, it may be assumed that furcation is involved, whereas this is furcation involvement in case of radiographically there will be radiolucency will be seen. The coming to the treatments, the main objective of the treatment for furcation involvement is, first of all we have to eliminate the plaque retention area, and then we have to facilitate self maintenance, that is by the patient, and to prevent further attachment loss and obliterate furcation defects like dental anomalies, and to restore normal function by regenerative processes, and if any pulpal pathology if it is present we have to correct it. Then coming to the treatments, the factors that affects the treatment, severity of the furcation invasion and amount of remaining bone support and status of the abutment teeth and strategic importance of the involved teeth, how much amount of bone loss that is in that particular tooth. And the various treatment procedures that includes for furcation is root coverage, odontoplasty, osteoplasty, root resection, hemisection, tunneling and and regenerative procedures. So first we are going to see the treatment procedures for different types of grades. For grade 1 treatment or degree 1, the scaling and root planning will be done. In case of grade 2, flap curettage, that is flap curettage along with odontoplasty, osteoplasty and osteotomy, that is furcationoplasty, will be done. In case of grade 3, root resection, hemisection along with regenerative procedures. In case of grade 2 also we will do regenerative procedures depending upon the amount of attachment and number of walls. The treatments are includes conservative treatment, regenerative treatment and resective treatment. First of all, we are going to see the non-surgical, that is conservative type of treatment. The non-surgical includes, first we are going to do the scaling and root planning procedures. So scaling and root planning in case of grade 1 and shallow grade 2, it gives excellent results, but in case of deeper sites it will give less favorable results. Earlier the furcation is detected either radiographically and it treated, good long term results will be obtained. Next we are going to see the next non-surgical treatment is local drug delivery. Only scaling and root planning alone does not provide long term advantages. It gives better results, but for long term purpose it will not be useful. So high concentration of antimicrobials which combined with conventional treatment, that is scaling and root planning, will give better results and during the supportive periodontal care. Next we are going to see the odontoplasty. Odontoplasty is defined as the reshaping of the tooth coronal to the furcation. This is in the area coronal to the furcation to improve access to the plaque control. And the main purpose of this odontoplasty is to eliminate any facial grooves, cervical enamel projections or enamel pearls. The potential complication of odontoplasty is there will be hypersensitivity and increased risk of root caries. Next we are going to see the surgical part of treatment. Next we are going to see the surgical part of treatment. Surgical treatment is indicated whenever there is a significant horizontal involvement of one or more furcations of a multi-rooted teeth, and in case of inadequate accessibility to the furcation area, and another one is persistence of inflammation even after adequate phase 1 therapy, that is scaling and root planning. So first we are going to see the furcationoplasty. What is furcationoplasty? Is odontoplasty plus osteoplasty and or osteotomy is called furcationoplasty. That is, we are going to eliminate any dental anomalies, that is cervical enamel projections, enamel pearls, like that in odontoplasty, along with bone deformities is there, means we have to correct it in the furcation area. It is the most effective in grade 2 furcation and removes the lip of the defect to reduce horizontal depth and bone ramps into the furcation to enhance plaque control. Here the plaque control will be enhanced. It will also reduce the probing depth. Tunneling. Next procedure is tunneling. It is indicated in case of short root trunk and wide separation angle and large divergence. These are the terminologies I have been explained earlier. So the drawbacks of this tunneling procedure is risk for sensitivity of the root and root caries. Next procedure is osseous surgical therapies divided into regenerative and resective procedures. So regenerative, the main aim of the regenerative procedure is to eliminate the defects in the furcation by regenerating the new bone, cementum and gingival attachment within the furcation area. So many surgical procedures using variety of graft materials have been tested, and it is regeneration is will have better prognosis in deep 2-wall or 3-wall components. 2-wall means number of walls remaining, that is in case of there are 2 walls will be present in the furcation site. So bone grafts are substitutes or bone substitutes and use of GTR membranes, that is guided tissue regeneration membranes and growth factors, or combination of these therapy will be helpful for grade 2 and grade 3 furcations. So regenerative, which first includes bone grafts. There will be 3 types of regeneration. One is osteogenesis, osteoconduction and osteoinduction. Osteogenesis is contains bone forming cells, and whereas osteoconduction is the bone graft which serves as a scaffold for bone formation. Whereas osteoinduction is the matrix of the grafting materials contains inducive substances which stimulate the bone for a regrowth of the alveolar bone and formation of new attachment. There will be little or no vascularity to support bone graft in case which success is limited in case of furcations, indicated where destruction of the furcation is only partial or where deep vertical lesions. Next, regenerative includes, first we have seen the earlier we have seen bone grafts and we have seen here GTR, that is guided tissue regeneration, so guided which significantly improves the horizontal clinical attachment and it also improves vertical attachment and reduction in the probe when it is used in combination with the bone grafts. So, for GTR, good predictability will be there whenever there is interproximal bone is located closer to the cemento-enamel junction, comprehensive debridement, membrane is properly positioned and there is adequate plaque control is there. Whereas limited predictability will be there when the morphology of the periodontal defect in root complex is often horizontal, whereas good predictability will be there whenever it is in vertical. So, anatomy of furcation prevents instrumentation in case of limited predictability, and changing gingival margins during healing may also cause sometimes exposure of the membrane. Next, we are going to see the regenerative, that is GTR with bone grafts. The predictability of connective tissue attachment gain is higher when using GTR along with bone grafts. And growth factors, which includes, there are various growth factors which includes enamel matrix derivative, platelet derived growth factor, fibroblast derived growth factor, bone morphogenic proteins and platelet concentrates. These growth factors have shown significant attachment gain in case of furcation defects. Next, coming to the resective type of, that is root resection. Root resection is the surgical removal of all or portion of tooth root. In this, the root portion will be removed. Hemisection. The hemisection means surgical separation of multi-rooted teeth, especially mandibular molar, through the furcation in such a way that root and associated portion of the crown may be removed or restored. Here the tooth will be split along with the crown and the root in the furcation area, and if bone loss is more, it will be removed or sometimes it can be restored. And bicuspidization. Bicuspidization simply means splitting of the teeth into two equal halves, that is splitting of mandibular molar and retaining the both fragments. In case of hemisection, the fragment will not be mostly will not be retained, whereas in case of bicuspidization, the fragment will be retained so as to change the molar into two separate units. In case of resection, we have mostly we have the doubt that which root is to resect. In case of resective therapy, we have many doubts that which root is to resect. That is, we have to decide based on the greatest amount of attachment loss is there, for which root we have to decide based on that, and we have to eliminate the furcation and produce easily maintainable and greatest number of anatomical problems or developmental anomalies are there. We have to decide based on that, and difficult for endodontist to treat. Based on these indications, we have to remove that best contributes to the elimination of periodontal problems on adjacent teeth. In this, there is greatest amount of bone loss which extends to the apical region. In this picture, we are going to eliminate this distal part of the root. Coming to the maintenance therapy. For maintenance therapy, it is very difficult in case, especially in cases of furcation areas. For interproximal areas, when there is close proximity of the roots, which complicates the oral hygiene. So, in these cases, superfloss which is effective. When roots are not such close, interproximal brushes are effective. For facial or lingual furcations, unit effort or interproximal brushes are useful. Coming to the extraction, that is, whenever we have to decide which tooth has to be extracted in whenever there is a furcation involvement. So, whenever there is an extensive attachment loss or endodontic or prosthetic therapy is questionable, or treatment will not result in maintainable area, and retained involved tooth will not improve the overall prognosis and risk factor for long term prognosis of overall treatment. These are the conditions we have to decide for extraction. The key to successful treatment of furcation involved teeth are the same as for any other periodontal problem, that is early diagnosis. Early diagnosis leads to the better prognosis and thorough treatment plan and good oral hygiene by the patient, especially in cases of furcation, then careful technical execution, that is well designed and implemented maintenance phase. Thank you for listening my class.